Welcome to the new section on hyper and hypoaldosteronism. In this particular section, we'll be discussing on the basics right from the aldosterone synthesis to the aldosterone action, and later on we'll be moving on to the etiology, clinical features, workup and the management of both hyper as well as hypoaldosteronism with special regards to hyperaldosteronism because that is a very, very important topic for any competitive exam in the world. So in the basics, we are going to start from the kidneys because kidneys play a very, very vital role in the renin-angiotensin-aldosterone axis where renin is going to give rise to the production of aldosterone in a multiple cascade way. So let us see how renin is going to help in aldosterone synthesis and what are the ways of secretion of this renin from the juxtaglomerular cells in the kidneys. So we all know there are some specialized form of cells on the afferent arteriole of the glomerulus called as juxtaglomerular cells, and these cells are a little different from other endothelial cells by having excess granularity, and this excess granularity we can understand because they are going to secrete this specialized molecule called renin, which is obviously a hormone. And these juxtaglomerular cells can release renin by a variety of triggers and variety of stimulus. One is obviously the volume. So whenever the intravascular volume is low or whenever the effective arterial blood volume is decreased, the juxtaglomerular cells are going to sense this because they are going to work like stretch receptors. And whenever the volume is low, or which means whenever I tell the perfusion is low to the kidneys, they are going to sense this because they will be encountering reduced amounts of stretch, and that is going to act as a trigger for the release of renin. And at the same time, the beta adrenergic pathway can also have a very, very important effect in production of renin because these juxtaglomerular cells also have this beta 1 receptors. And at the same time, the stimulus to juxtaglomerular cells to secrete renin can also come from a very, very important prostaglandin called prostaglandin I2, which is otherwise referred to as a prostacyclin. And this prostaglandin is going to come from another specialized group of cells, which are nothing but specialized form of tubular cells that are located in the distal convoluted tubule, which are referred to as macula densa. And this macula densa is going to sense the urinary sodium, which means whenever the tubular sodium is low, and this will be sensed by the macula densa, which is going to form important stimulus for the production of this prostaglandin I2, which in turn is a very important stimulus for the juxtaglomerular cells to produce renin. So renin is going to basically come from three stimulus. One is by the perfusion. So when the perfusion is low or the intravascular volume is low, you're going to result in renin secretion. Number two, by adrenergic pathway, by stimulation of this beta 1 receptors in the JG cells. And number three is coming from the macula densa, where whenever the tubular sodium is low, you're going to result in prostaglandin I2 secretion. So this prostaglandin is very, very important for the production of renin as well. So once renin is produced, renin is going to convert a substance known as angiotensinogen, and this angiotensinogen is coming from the liver, and the renin is going to convert angiotensinogen to angiotensin 1. And angiotensin 1 will be processed further by the pulmonary capillaries, and pulmonary microcirculation is very, very important in this regard because this pulmonary microcirculation has a very important enzyme called angiotensin converting enzyme. And this angiotensin converting enzyme is going to convert this angiotensin 1 to angiotensin 2. And angiotensin 2 is a very, very important molecule, and angiotensin 2 is going to exert its action through two types of receptors. One is called angiotensin type 1 receptor, AT1 receptor, or we have another type of receptor called angiotensin 2 receptor called AT2 receptor. Out of these two receptors, this AT1 receptor is going to be the most important. Through AT1 receptors, it can exert a variety of functions, like for example, vasoconstriction. Vasoconstriction can happen widespread with special regards to the efferent arterioles of the kidneys, which we'll be discussing more in the nephrology section. And number two, on the hypothalamus to increase the thirst. And number three, it can produce increased sodium reabsorption on its own, but the majority of its effects is actually mediated through aldosterone. But anyways, it can directly increase the sodium reabsorption in the kidneys, especially on the proximal part of the nephron. And it can act on the zona glomerulosa as well in the adrenal cortex to increase the aldosterone production. Because stimulation of the AT1 receptor by angiotensin II is going to activate a type of enzyme called CYP11B2, which is otherwise referred to as aldosterone synthase enzyme, and this is going to increase the production of aldosterone from the zona glomerulosa cells. The details of this CYP11B2 is solely controlled by angiotensin II and partly by potassium, has been discussed in detail in the steroidogenesis section itself. But the molecular mechanisms of how a zona glomerulosa cell is going to increase the production of aldosterone is relatively important to understand certain familial forms of hyperaldosteronism. So we know that the zona glomerulosa cell is going to have this AT1 receptor, which is going to be activated by angiotensin II. And we also have to know the fact that this AT1 receptor is a GQ type of receptor, which means they are going to work by phospholipase C pathway. So once phospholipase C is produced, that is going to stimulate a type of calcium channel, and stimulation of this voltage gated calcium channels will result in influx of calcium into the cell. And this excess calcium is going to bind with a molecule called as calmodulin, and formation of this calcium calmodulin complex is very important for the activation of our famous CYP11B2 enzyme, which is otherwise referred to as aldosterone synthase, which is going to result in increased production of aldosterone. Remember, increased production of aldosterone. Similarly, this CYP11B2 enzyme can also be stimulated by potassium, and potassium into the cell can come through another channel called as KCNJ5, and which means the zona glomerulosa cells sense the potassium through this KCNJ5 channels. And this is very important to understand, because problems with the calcium channels or problems with the potassium channels, where there will be more leak of calcium or more leak of potassium, can result in excessive aldosterone production by stimulation of this CYP11B2 enzyme, and that forms the basis of some of the familial type of hyperaldosteronism. And once increased amount of aldosterone is produced and once aldosterone is released into the circulation, aldosterone is going to bind to its natural mineralocorticoid receptor, and binding of the aldosterone on the mineralocorticoid receptor is going to result in variety of functions. So the more importantly, there are many mineralocorticoid responsive tissues. One of the most important mineralocorticoid responsive tissues is the kidney. But remember, there are three classic mineralocorticoid responsive tissues: the kidneys, colon, and the sweat glands. But let us now understand how a kidney functions. So we have a type of cell called as a P cell, or otherwise referred to as a principal cell. Whenever aldosterone binds to the mineralocorticoid receptor in the P cells of the kidney, they are going to result in increased production and activity of a particular type of sodium channel called as epithelial sodium channels, or otherwise referred to as ENaC sodium channels. An increased production and activity of these ENaC channels is going to result in increased sodium reabsorption from the urine, because these ENaC channels will be inserted on the luminal side, or otherwise referred to as apical side of the nephron. That's a very important point. Remember, binding of aldosterone with the mineralocorticoid receptor will not only increase the production of these ENaC channels, it's also going to increase the production of another pump called as sodium potassium ATPase. This is fairly important because the sodium potassium ATPase will be actually inserted on the basolateral side of the membrane, because whatever sodium that is reabsorbed by the ENaC channels has to be pushed out through this basolateral sodium potassium ATPase. And this also concentrates potassium within the cell, and this potassium concentration into the cell is not the sole reason for the movement of potassium out of the cell, because cells can store any amount of potassium and they are storehouses of potassium. And movement of potassium out of the cell is mediated through a particular type of channel called ROMK channel, otherwise referred to as renal outer medullary potassium channels. And as I told you before, just mere concentration of potassium into the cell is not the reason for the movement of potassium outside. To move this potassium outside the principal cell or the collecting duct cell, you need another event that is actually created by the movement of sodium into the cell by the ENaC channels. So this movement of sodium into the cell by the ENaC channels is going to create a strong electronegativity on the luminal side of the membrane, and this acts as a strong driving force for the potassium to move out of the cell. So which means this movement of sodium inside the cell is important for the movement of potassium out of the cell. Which means whenever you have increased sodium reabsorption, you are going to result in increased potassium secretion as well. And this creation of negative charges by movement of sodium into the cell is also important for movement of hydrogen ions out of the cell. Which means what are going to be the effects of aldosterone action? Aldosterone is going to increase sodium reabsorption. There's no doubt about that. And as a result of increased sodium reabsorption, you are going to result in increased potassium secretion as well as increased H+ secretion. And remember the fact, cortisol also has a very, very decent affinity for this mineralocorticoid receptors. And these mineralocorticoid responsive tissues has to be shielded or protected from the cortisol, from binding with the mineralocorticoid receptors, and this shielding effect is actually done by a very, very important enzyme that is called as 11-beta HSD2. 11-beta HSD2, which is going to convert our cortisol to inactive cortisone, which means this cortisone has glucocorticoid activity, but cortisone does not have any mineralocorticoid activity. Which means our mineralocorticoid responsive tissues like colon, sweat glands in the kidney are shielded literally from the effects of cortisol by 11-beta HSD2 enzyme. And now let us understand what will happen whenever there is excessive aldosterone. Whenever you have an excessive aldosterone, you're going to result in too much of sodium reabsorption, and this is going to result in volume overload state. And this volume overload that happens is usually very mild, but this is enough to produce significant amount of hypertension. We are talking about a primary hyperaldosteronic states. Remember, there are many types of hyperaldosteronism. I'm talking about a primary increase in aldosterone. I'm not talking about secondary cause of hyperaldosteronism. Any primary aldosterone excess will result in definitely hypertension. Most of the time, this hypertension tends to be resistant in nature. And this is due to volume overload state. So what volume overload does? Volume overload is going to increase the preload, obviously. Whenever the preload increases, your stroke volume will increase, and that is the reason for developing systolic hypertension. And at the same time, increased amount of volume that is circulating in the blood can result in increased systemic vascular resistance, because this is a reactive type of vasoconstriction resulting in increased systemic vascular resistance, and that is the reason why you have increased diastolic blood pressure as well. And volume overload is generally mild, as I told you before, where the patient will have a weight gain of approximately 3 kilograms, but not more than that. But more importantly, this volume overload that happens with primary types of hyperaldosteronism will not produce edema. And usually edema will not be a feature. Why you don't get an edema and why you get only mild volume overload and mild weight gain despite having high aldosterone in the blood and more sodium reabsorption? This is because of a principle referred to as aldosterone escape. So what are the basic mechanisms behind this aldosterone escape that will help in not generating too much of volume overload and not producing edema and too much of weight gain? The first reason is because this volume overload can activate the natriuretic peptide release from the heart. This natriuretic peptide release from the heart will result in increased sodium excretion, and that might play a very, very important role in maintaining the volume. And the second important mechanism is going to come in the form of pressure natriuresis, where hypertension and increased blood pressure itself, by sheer pressure, it's going to increase the sodium filtration, which will in turn increase the excretion of sodium in the urine. So which might explain the maintenance of volume in these patients. And third mechanism is reduced activity of sodium chloride transporters that happens as a result of increased urinary sodium due to pressure natriuresis. And that might also explain a relatively low sodium reabsorption compared to what you will expect in a case of a primary hyperaldosteronism, thereby maintaining the volume status in the body. And number 4, primary hyperaldosteronism cases will have low angiotensin II because by feedback, because of excess aldosterone, there's going to be low renin production, and low renin will have low angiotensin II. As I told you, angiotensin II is more than a decent hormone to produce increased sodium reabsorption from both proximal as well as distal parts of the nephron, in which proximal part of the nephron is the most important site of angiotensin II action. So because of the reduced amount of angiotensin II, this might hinder with the sodium reabsorption in the nephron, resulting in a relatively more sodium excretion compared to what you expect in a patient with a primary hyperaldosteronism. And these mechanisms might constitute to the development of only mild volume overload and no development of edema, which is famously referred to as a phenomenon called aldosterone escape in a patient with primary hyperaldosteronism. And apart from that, as I told you, this increase in sodium reabsorption is actually associated with increased potassium excretion, resulting in hypokalemia. And trust me, this hypokalemia is a very, very inconsistent finding in a case of a primary hyperaldosteronism, and you don't even see hypokalemia in a case of secondary hyperaldosteronism. Usually, in a primary hyperaldosteronism, you will see hypokalemia in only 30 to 50% of the cases, which means it's a very inconsistent finding. And a patient with secondary hyperaldosteronism, especially in those with reduced effective arterial blood volume, resulting in more renin, because of that more angiotensin, because of that more aldosterone, you will have a normal serum potassium. What is the reason? There are multiple reasons behind that. So first, let us understand what is the reason for hypokalemia, that is increased sodium reabsorption. Remember, this increased sodium reabsorption is not the only reason for development of hypokalemia. There are multiple things that determine the excretion of potassium from the nephron. So what are the things that determine the excretion of potassium from the nephron? One is the sodium delivery. Obviously, the amount of sodium that is delivered to the distal part of the nephron is very, very important, because the more the amount of sodium that is delivered, more will the potassium that will be secreted, resulting in more and more hypokalemia. So sodium delivery is a very, very important regulator of potassium excretion from the distal part of the nephron. And number 2 is the urinary flow. So more is going to be the flow of the urine, more is going to be the washout of potassium, which means urinary flow plays a very, very important role in the excretion of potassium. So that is also the reason why in patients with AK or CKD or anuric patients, they rapidly develop hyperkalemia, because of the very poor urinary flow. And at the same time, patients who are having primary polydipsia, they have more urinary flow all the time. And that's also one of the reasons certain primary polydipsia patients can develop hypokalemia as well. And number 3 is the mineralocorticoid activity, which means presence of aldosterone and its action on the aldosterone receptor. Mineralocorticoid receptor is very, very important for the insertion of these ENaC channels and proper functioning of these ENaC channels to produce sodium reabsorption, thereby producing excretion of potassium. And number 4, more importantly, non-absorbable anions that are present in the tubular lumen. And this will help you in understanding why you get hypokalemia in conditions like diabetic ketoacidosis. Because, as I told you, the reason why sodium reabsorption is coupled with potassium excretion is the fact that you tend to create this electronegativity on the luminal side or the apical side of the membrane. So whenever you are going to have this non-absorbable anions, so there are non-absorbable anions which cannot be absorbed because chloride is an absorbable anion. So leave the chloride. We are not talking about chloride here. So you are talking about non-absorbable anions. For that matters, we are talking about agents like beta hydroxybutyrate, which is increased in ketoacidotic states, and probably anions like toluene. So toluene poisoning. So in these conditions, these non-absorbable anions are going to create this electronegativity because they are non-absorbable and they stick onto the walls and they create this electronegativity, and this might result in sucking out of this potassium out of the cell, resulting in hypokalemia. So this also explains why in diabetic ketoacidosis you can get hypokalemia as well. So why you don't develop hypokalemia in a case of primary hyperaldosteronism, and why it is an inconsistent finding, why in very few cases you develop hypokalemia. So for that you have to understand one important principle, that you don't need to develop hypokalemia just because of one particular mechanism. You need to have a combination of mechanisms to produce hypokalemia. Just one mechanism alone will not result in development of hypokalemia. You need to produce a combination of mechanisms to produce hypokalemia in the individual. So majority of these patients with primary hyperaldosteronism, due to unknown reasons, they might regulate their salt intake. And a patient who's having low salt intake usually tend to have a normokalemia only, and they do not tend to have a hypokalemia. And when they develop hypokalemia, whenever they take a more salt. Why low salt intake is associated with normal potassium in these patients? Because as I told you, whenever you take a low salt, these patients tend to have a lower sodium delivery in the distal nephron. Because of low sodium delivery, the potassium excretion may not be that great despite having more aldosterone. So you might result in a normal potassium. So that is the reason whenever you increase the distal sodium delivery in these patients, you might actually result in development of hypokalemia or even result in worsening or severe hypokalemia in these patients. So what are the conditions normally that increase the distal sodium delivery? Whenever you increase the sodium intake in these patients, which means whenever these patients tend to take more salt, they tend to develop hypokalemia. And whenever you start with diuretics in these patients, like loop diuretics or thiazide diuretics, that is going to increase the distal sodium delivery, and that might precipitate more and more hypokalemia, in fact even a severe hypokalemia. Otherwise, these patients tend to have a inconsistent hypokalemia, which means this low potassium is seen only in 30 to 50% of the cases, and even in these patients it tends to be relatively mild, not like very severe hypokalemia like what you expect. And secondary hyperaldosteronism is not associated with the development of hypokalemia, especially in conditions that are associated with low ABV states. Classical examples include cirrhosis, congestive heart failure, and nephrotic syndrome, which are associated with low ABV, and because of that activation of RAS system, and they have very high aldosterone levels usually in these individuals. And why they tend to have a normal serum potassium, it can be clearly explained by the fact that they have low ABV. Whenever you have a low ABV, you will have a low distal sodium delivery. And there are multiple reasons for this. One, they tend to have low perfusion pressure. So because of the low perfusion pressure, they will result in more angiotensin II production. Because of the more angiotensin II production, I told you angiotensin II is more than a decent hormone to increase sodium reabsorption from the proximal portions of the nephron. So that will result in more sodium reabsorption from the proximal portions of the nephron, which might result in reduced distal sodium delivery. And low ABV obviously will result in low sodium filtration as well. That will result in overall decline in the urine sodium. And at the same time, they'll also result in low urine flow, because urine will not be produced as much as you expect whenever the patient is suffering from severe hypovolemia, at least low effective arterial blood volume. And because of the same, there will be reduced distal sodium delivery, and because of the reduced distal sodium delivery, these patients tend to have normal serum potassium because you don't have enough sodium to exchange for this potassium in the distal nephron. So unless and until you give a diuretic agent that increases the sodium delivery in these individuals, you cannot produce hypokalemia in these states. So as a nutshell, I can tell in patients with primary hyperaldosteronism, hypokalemia is a very inconsistent finding. But even if you have hypokalemia, they generally tend to be mild, and precipitation of hypokalemia happens whenever you are going to increase the salt intake in these individuals, or if the patient is being given with some diuretic agent that increases the distal sodium delivery. And patients with secondary hyperaldosteronism, as I told you, they didn't have a normal serum potassium, and precipitation of hypokalemia in these individuals will result only when you give a diuretic agent, because that is going to increase the distal sodium delivery. And we have not yet discussed or commented on the third effect of hyperaldosteronism, that is metabolic alkalosis, which is a very, very important point as well. So final nutshell, so whenever you have a high aldosterone, you're going to result in excessive sodium reabsorption, definitely, which will result in volume overload state, which will be mild. They will have surely hypertension, but not that much volume overload like what you expect, and they do not generally tend to have a edema. And hypokalemia, very, very inconsistent. And third effect is metabolic alkalosis. And fourth effect, which is often not studied properly, is the cardiovascular effects of high aldosterone. Remember, aldosterone in excess is going to produce hypertension, especially primary hyperaldosteronism. We know that. And when you compare other patients with hypertension, for example, a systemic hypertension and a primary hyperaldosteronism patients causing hypertension, and for the same level of BP, patients with primary hyperaldosteronism tend to have more cardiovascular adverse effects compared to patients with systemic hypertension. This can be due to direct cardiac remodeling effects of high aldosterone. Aldosterone may have a cardiac remodeling effect, and probably due to volume overload created by high aldosterone. So this could be the probable explanation why they tend to have more adverse cardiovascular effects compared to other patients with the same BP due to other causes. And patients with primary hyperaldosteronism tend to have more metabolic syndrome like obesity and dyslipidemia compared to other patients, and this also explains why they tend to have more cardiovascular adverse effects compared to other patients. So you have to know that patients with primary hyperaldosteronism tend to have more adverse cardiovascular effects compared to other patients with hypertension with the same level of BP. And obviously you will be knowing the effects of hypoaldosteronism. Obviously, it's going to be the opposite of hyperaldosteronism, where you're going to have low sodium reabsorption and salt wasting, and the patients will be having hyperkalemia, and the patient will be having metabolic acidosis, which will be normal anion gap metabolic acidosis. Fine, these are the effects of hypoaldosteronism. So having known about the effects of hyper as well as hypoaldosteronism, and the physiology behind them. So because this understanding of physiology is very, very important, let us move on to the etiology and causes of hyperaldosteronism. Hyperaldosteronism can be due to excessive renin. So because whenever you have a increased renin, so which I'm going to shade in brown, so whenever you're going to have an increased renin, you can have increased angiotensin II. Because of the same, you will be resulting in more production of aldosterone. And this type of hyperaldosteronism we also call as hyperreninemic hyperaldosteronism or secondary hyperaldosteronism. So when I write secondary hyperaldosteronism, obviously we know it is due to excessive renin, and this hyperreninism can be a primary renin excess, which means secondary hyperaldosteronism can be due to primary hyperreninism or a secondary increase in renin, secondary renin excess. Primary hyperreninism is extremely rare, but a very important cause is renin secreting tumor. A renin secreting tumor can produce increased renin as well as increased angiotensin II and aldosterone subsequently, and they may produce hypertension with the inconsistent hypokalemia mimicking a primary hyperaldosteronism. But obviously investigations will tell otherwise. A secondary hyperrenism is usually due to low perfusion to the kidneys, and this low perfusion can be due to a vascular cause causing low perfusion, or it can be due to low effective arterial blood volume, which means low circulating volume resulting in low perfusion to the kidneys, resulting in reduced stretch of the juxtaglomerular cells, resulting in more production of renin and subsequently more production of angiotensin II and aldosterone. Vascular events, for example, you have a renovascular hypertension which can be due to renal artery stenosis like atherosclerotic RAS or fibromuscular dysplasia, which we'll be discussing in detail in nephrology section. Or it could be due to vasculitis, especially affecting the renal vessels like polyarteritis nodosa, or it could be multiple other causes. Second condition is coarctation of aorta, which closely mimics the pathophysiology of renovascular hypertension. And similarly, malignant hypertension also follows very similar pathophysiology to that of renovascular hypertension. And these patients with vascular cause of secondary hyperaldosteronism tend to have hypertension, obviously. At the same time, they tend to have an inconsistent hypokalemia where they can mimic a primary hyperaldosteronism picture. And conditions that have low ABV include cirrhosis, classical 3 causes: cirrhosis, nephrotic syndrome, and congestive heart failure, and obviously use of diuretics, and conditions that mimic the use of diuretics like Barter's syndrome and Gitelman syndrome. Strikingly, these patients who have low ABV related hyperaldosteronism, which is very, very common compared to other cause of hyperaldosteronism, tend to have a normal BP usually. In fact, most of them tend to have a low borderline BP because they have depleted intravascular volume. That is the reason. And they tend to have a normal serum potassium unless and until you give a diuretic agent that's going to precipitate development of hypokalemia. And as the name suggests, treatment of secondary hyperaldosteronism will be directed against the underlying cause because it's secondary to some underlying problem. So treat that hyperaldosteronism in these conditions will be corrected. So now we are moving on to the ever important primary hyperaldosteronism, which means there is aldosterone excess in these patients, but this excessive aldosterone is not due to renin and angiotensin II, which means there will be suppressed renin in these individuals, and this low plasma renin concentration and high plasma aldosterone concentration is very, very important defining criteria for diagnosing these disorders. And who's going to secrete this excessive aldosterone? Usually by the zona glomerulosa cells or sometimes fascicular cells from the adrenal gland, which means that localizes the problem in the adrenal glands. Problem in the adrenal glands can be a structural problem or it could be a functional problem. Functional problem in the sense there could be problems in this KCNJ5 genes, or it could be problems in the angiotensin I receptor, or even there could be problems in the calcium channels that are controlling the aldosterone production in this regards, which we have discussed in the previous slide itself regarding how these are going to affect the aldosterone production. Structural problems come in the form of an adrenocortical adenoma, which means in this perspective it is a functional adrenocortical adenoma where aldosterone producing adenoma producing hyperaldosteronism is what we refer to as CON syndrome. Structural causes generally tend to be unilateral and functional causes generally tend to be bilateral in nature, as I told you already. Second structural cause is a rare cause, that's an adrenocortical carcinoma. But adrenocortical carcinoma producing only aldosterone is generally very rare. They tend to produce mixed bag of metabolites in general, not only the aldosterone. Functional causes can be hyperplasia, and this hyperplasia can be idiopathic, and it is supposed to be due to gain of function mutation of AT1 receptor, which is going to bind the angiotensin II, which means if there is a gain of function mutation of this AT1 receptor, they can transmit more signaling, which can result in more production of aldosterone. Similarly, it can be due to congenital adrenal hyperplasia, especially certain salt-retaining forms of congenital adrenal hyperplasia, like classic CYP11B1 deficiencies or 17-hydroxylase deficiencies can result in development of hypertension in children in this enzyme deficiencies. And second, it can be due to some familial causes like familial hyperaldosteronism. Remember, congenital adrenal hyperplasia tends to be autosomal recessive in inheritance, whereas familial types of hyperaldosteronism tends to be autosomal dominant in inheritance. And there are many different types are there, where you have a type 1 familial hyperaldosteronism, which is otherwise referred to as a glucocorticoid remediable aldosteronism, the details of which I have described in detail in the basics of adrenal section itself, where there will be formation of a chimeric gene between this 11B1 and 11B2, and now because of the formation of chimeric gene due to unequal crossing over, this aldosterone synthase coding region will be coupled with the promoter of the 11B1 enzyme. So which means the new chimeric aldosterone synthase enzyme, that is 11B2, will be under the control of ACTH because the promoter is made of 11B1's promoter, which I have described in the basic section itself. So now there will be ACTH regulated aldosterone production that happens from the zona fasciculata instead of zona glomerulosa, that results in more aldosterone production causing hyperaldosteronism, type 1 familial hyperaldosteronism, which is glucocorticoid remediable, and that will respond to steroids. And we have a type 2 familial hyperaldosteronism whose cause is unknown due to unknown genetic mutations, and we have a type 3 familial hyperaldosteronism, which is usually due to mutation in the KCNJ5 gene. If you have a problem in this KCNJ5 gene and KCNJ5 channel, there can be increased influx of potassium resulting in more sensing of potassium by zona glomerulosa cells, resulting in more activation of CYP11B2 and more production of aldosterone. And we have a type 4 familial hyperaldosteronism, which is due to mutations of calcium channel, especially subunit 1H, that is related to the zona glomerulosa. And we have another disorder called PASNA, which is an acronym that stands for primary aldosteronism with seizures and neurological abnormalities. And this is again due to mutation in a calcium channel, especially with the subunit 1D. And obviously you can understand whenever there is mutation in this calcium channels, that can result in more influx of calcium, resulting in more formation of calcium calmodulin complex, resulting in more activation of CYP11B2 and more aldosterone production. Clear? And please do understand, this PASNA is not a familial disorder, to be honest, but it's a genetic disorder because these patients generally don't transmit the infection. They don't have any inheritance pattern as such. But apart from the type 1, type 2, type 3, type 4 generally tend to have an autosomal dominant pattern of inheritance. So treatment will be dependent on whether it's a structural or a functional problem. If it's a structural problem, you are going to do unilateral adrenalectomy. If it's a functional problem, the treatment depends. You can treat with steroids in certain patients like congenital adrenal hyperplasia and GRA, and you can treat with mineralocorticoid receptor antagonists in other cases, or in exceptionally severe cases, you can even treat with your bilateral adrenalectomy. Fine. We'll compare and contrast about the types of familial hyperaldosteronism. The most important 3 types we'll be comparing and contrasting, that is type 1, type 2 and type 3. Remember, almost all these types which I have described are autosomal dominant inheritance, and we know what is the problem in type 1. Type 1 familial hyperaldosteronism is also referred to as a GRA, which means they're going to form a chimeric gene or a hybrid gene between CYP11B1 and CYP11B2, where they will be having coding region that is formed of aldosterone synthase, that is CYP11B2, and the promoter will be made of CYP11B1, and they will be responding to ACTH, and it's a ACTH mediated release of aldosterone from zona fasciculata, and that is the reason for hyperaldosteronism here. And in type 2, we don't know what is the real reason here, but genome-wide sequencing analysis tells that the region that is associated with this type 2 familial hyperaldosteronism is mapped in the 7p22 area. So that might be the question in exam. And type 3, we know it is due to KCNJ5 channel mutation or KCNJ5 gene mutation, resulting in more potassium influx into the cell, resulting in more sensing and hyperaldosteronism. Type 1 generally tends to happen in young adults or young patients, but even though it is variable, type 2 generally tends to happen in adults. Type 3 is actually variable, but even though it is quite common in childhood. Similarly, potassium tends to be normal to low serum potassium, but remember in exam, GRA always answer normal serum potassium, even though, the hypokalemia is very inconsistent finding in any condition that causes primary hyperaldosteronism, but it's traditional to understand that GRA tends to have a normal serum potassium. That's very important for exams. Similarly, type 2 also tend to have a normal to low serum potassium, but type 3 usually tend to have a hypokalemia. That's not only due to hyperaldosteronism, that is also due to movement of potassium all the time into the cells, resulting in more potassium inside the cell than outside, resulting in sure development of hypokalemia in these individuals. And what about dexamethasone suppression? Yes, dexamethasone will suppress the aldosterone output from the zona fasciculata in patients who are having type 1 familial hyperaldosteronism. That's a very important diagnostic point as well. But there will be a partial response, not a complete response. There will be a partial response to dexamethasone in case of type 2 hyperaldosteronism, but there will be no response to dexamethasone suppression as far as type 3 is concerned. And imaging wise, they tend to have normal adrenal glands, these type 1 patients. Type 2 patients may have a bilateral adrenal hyperplasia or even a aldosterone producing adenoma on imaging. And type 3 patients tend to have a marked bilateral adrenal hyperplasia, which means if they ask you which of the following types of familial hyperaldosteronism tends to have a normal adrenal gland on imaging, answer is type 1. That is glucocorticoid remediable hyperaldosteronism. Whereas type 2 and type 3 may have abnormal imaging features like bilateral adrenal hyperplasia or probably an aldosterone producing adenoma in case of a type 2 familial hyperaldosteronism. And having discussed about the causes of primary hyperaldosteronism, let us move on to some other conditions which mimic hyperaldosteronism but not due to hyperaldosteronism, which means first condition I'm going to discuss is about excess activation of this mineralocorticoid receptor. So whenever there is excess activation of mineralocorticoid receptor, but it is not due to aldosterone, not by aldosterone. So which means aldosterone is not the culprit here, but there is some other compound that is activating the mineralocorticoid receptor. And this is what we refer to as a condition called apparent mineralocorticoid excess or syndrome of apparent mineralocorticoid excess called as SAME. So for example, your exogenous mineralocorticoids can activate the mineralocorticoid receptor, like if the patient is on fludrocortisone, knowingly or unknowingly, that can activate the mineralocorticoid receptors and can produce obviously hyperaldosteronism features, but aldosterone levels will be suppressed in this regards. And at the same time, patients who are having reduced 11-beta HSD2 activity, which can be either congenital or acquired due to black licorice ingestion, as we discussed already in the basic section. So this reduced 11-beta HSD2 activity means the shielding effect of this mineralocorticoid responsive tissues to cortisol is lost, which means you're going to result in increased cortisol action on the mineralocorticoid receptor, producing more mineralocorticoid effects than necessary, resulting in hyperaldosteronism like picture, but actually the aldosterone levels will be low in this regards. Or another condition that can produce conditions similar to apparent mineralocorticoid excess is activation of this ENaC channels. That's a gain of function mutation of this epithelial sodium channels, which is autosomal dominant disorder called as Liddle syndrome. It's a very important topic again. So these are the conditions that will result in production of mineralocorticoid excess like states, but there will be low levels of aldosterone, and it could be due to either apparent mineralocorticoid excess or due to a gain of function mutation of ENaC channels in the form of Liddle syndrome. Let us summarize the causes now in a nutshell. So whenever you have either a hyperaldosteronism or clinical features that are suggestive of hyperaldosteronism, your causes can be a secondary hyperaldosteronism, which is far more common than primary hyperaldosteronism, and third group of disorders we know already, these are non-aldosterone mineralocorticoid excess states. Secondary hyperaldosteronism is very common, but you know what are the reasons for that. It is due to excessive renin, hyperreninemic hyperaldosteronism, and this excessive renin may be due to primary increase in renin, or it could be due to a secondary increase in renin. Primary increase in renin, in exam you have to remember this renin secreting tumors, and secondary hyperrenism is usually due to low perfusion to the kidneys. Low perfusion can be due to vascular cause, like for example renovascular hypertension, coarctation of aorta, or it could be malignant hypertension, or it could be conditions that produce low effective arterial blood volume or low circulating intravascular volume, which is classically due to cirrhosis, CHF and nephrotic syndrome, or it can be due to diuretic use or conditions that mimic diuretic use like Bartter syndrome and Gitelman syndrome. And primary hyperaldosteronism can be once again classified into structural causes, which are mostly unilateral, or functional causes, which are bilateral, and aldosterone producing adenoma is a structural cause, and the condition is called as Conn syndrome, or it could be a aldosterone producing carcinoma, but generally that is quite very rare. The bilateral causes can be hyperplasia, which could be congenital or idiopathic due to AT1 receptor mutation, or it could be due to familial causes like familial hyperaldosteronism. We have discussed a whole lot of different types of familial hyperaldosteronism. And non-aldosterone mineralocorticoid excess you can classify into conditions that produce apparent mineralocorticoid excess or Liddle syndrome. Apparent mineralocorticoid excess is usually due to exogenous mineralocorticoids, which will be very, very apparent in with appropriate history taking, where the patient will be, obviously admitting to the steroid use or this mineralocorticoid use. Or if you still have doubt, you can do a urinary steroid profile to find out the culprit steroid that is hidden inside the body. 11-beta-HSD2 defects can be identified by very simple test called as urinary cortisone to cortisol levels. Ratio will be seen, where the ratio, if it's less than 1, it suggests 11-beta-HSD2 defect because it tells you the urinary cortisol levels are very, very low. Or alternatively, you can do a urinary cortisol to cortisone. Obviously, you know the cortisone is going to be low and cortisol is going to be high in these patients with 11-beta-HSD defect, and the ratio, if it's more than 5 or more than 10, normally the ratio must be up to 1.2. If it's more than 5 or more than 10, you can tell there is 11-beta-HSD2 defect. At the same time, these patients respond very nicely to spironolactone, that is mineralocorticoid receptor antagonists. But they have a very poor response to amiloride. Why I told that point? I'll tell you in some time. Because you have another syndrome called Liddle syndrome, which can closely mimic this apparent mineralocorticoid excess, where the problem is the gain of function mutation of the gamma subunit of the ENaC channels, and it is autosomal dominant in inheritance. And Liddle syndrome can be identified clinically by its absolute response to amiloride, because amiloride along with triamterene is a potassium sparing diuretic that blocks the ENaC channels. Because amiloride blocks the ENaC channels, they show very, very good response in Liddle syndrome. But there will be poor response to mineralocorticoid receptor antagonists, and this is also one important clinical difference between Liddle syndrome versus 11-beta-HSD2 defect producing apparent mineralocorticoid excess. In doubtful cases, obviously you have to go for genetic testing, where you have to find out the gain of function mutation of the gamma subunit of the ENaC channel. So let us discuss the clinical features one more time. These renin secreting tumors will have hypertension and inconsistent hypokalemia, as I described already. And these vascular problems like renovascular hypertension tend to have hypertension and inconsistent hypokalemia as well. And this low ABV states, especially cirrhosis, CHF, and nephrotic syndrome, tend to have a normal BP, even a low borderline BP. Nephrotic syndrome patients sometimes may have hypertension as well, and they tend to have a normal serum potassium. This is the most important point, unless and until you precipitate hypokalemia with diuretics. Primary hyperaldosteronism tend to have hypertension, but they do not have edema or severe volume overload state because of the aldosterone escape, which I have described already, and they tend to have a inconsistent hypokalemia, where hypokalemia will be seen only in 30 to 50% of the cases. And non-aldosterone mineralocorticoid excess, once again they will be having hypertension with the inconsistent hypokalemia. Fine, all right. How we are going to identify, we are going to treat these disorders. As I told you already, secondary hyperaldosteronism, you are going to treat the underlying cause. That's it. So if you treat the underlying cause, that must be more than enough. If you are sure about the structural causes of primary hyperaldosteronism, unilateral causes, then your appropriate treatment option will be unilateral adrenalectomy. That's the best treatment option. In bilateral functional causes, it depends. For example, if it's a congenital adrenal hyperplasia, or if it's a familial hyperaldosteronism type 1, that is glucocorticoid remediable hyperaldosteronism, in this condition you can give steroids which show an excellent response, plus or minus you can use a mineralocorticoid receptor antagonist like spironolactone, which will be very responsive as well. In patients who are having familial hyperaldosteronism type 2 to type 4, you try treating with mineralocorticoid receptor antagonist, or if the patient is having severe hyperplasia or aldosterone producing adenoma, you can even go for a bilateral adrenalectomy in this regards. Clear? In patients with exogenous mineralocorticoid use, treatment will be stopping the exogenous mineralocorticoids or continuing at the lower dose, maybe whatever is appropriate if it's essential. In patients who are having 11 beta HSD defect, obviously the treatment will be stopping the licorice if the patient is taking, or you can use this mineralocorticoid receptor antagonist, which is going to show a very, very good response. In patients who are suffering from Liddle syndrome, obviously they are going to respond very nicely to amiloride, so treatment of choice becomes amiloride. So this is how you treat this hyperaldosteronic states depending on the etiology. Now let us move on to the approach to hyperaldosteronism. Remember, secondary hyperaldosteronism due to clear-cut low intravascular volume related causes need not be evaluated. For example, patients with CHF, nephrotic syndrome or cirrhosis, they will definitely have hyperaldosteronism, and that is secondary to the underlying cause, and they need not be evaluated at all. Clear? So only patients who are having suspected primary hyperaldosteronism and probably other causes of hyperaldosteronism need to be evaluated. For example, patients who are having hypertension with hypokalemia plus or minus an adrenal mass, and adrenal incidentaloma with hypokalemia and hypertension definitely has to be evaluated with the next step, that is aldosterone renin ratio. So for example, if they ask you what will you do as a next step in a patient who is having hypertension and hypokalemia, your answer must be aldosterone renin ratio, which is the next best step. So how will you do an aldosterone renin ratio? You're going to do plasma aldosterone concentration divided by plasma renin activity, and you're going to get the aldosterone renin ratio. Remember, there are some drugs that alter the aldosterone renin ratio, which means there are some drugs which can increase the aldosterone renin ratio. For example, beta blockers and central drugs like clonidine, alpha methyl dopa, these drugs can increase the aldosterone renin ratio. So because of the same, especially beta blockers, which are very commonly used drugs, has to be stopped at least 2 to 4 weeks before the test. And similarly, there are some drugs that can reduce the aldosterone renin ratio. For that matters, ACE inhibitors and ARBs, very, very important drugs, and very easily understandable that they are going to reduce the aldosterone renin ratio. And drugs like mineralocorticoid receptor antagonists like spironolactone and eplerenone can also drastically reduce the aldosterone renin ratio, and because of the same reason, your angiotensin receptor blockers and ACE inhibitors has to be stopped at least 2 to 4 weeks prior to the testing, and mineralocorticoid receptor antagonist has to be stopped at least 6 weeks prior to the testing of aldosterone renin ratio. So if they ask you what are safe drugs, calcium channel blockers relatively safe and they do not have much effect on the aldosterone renin ratio. So you can use these drugs to control the BP. And peripheral alpha blockers like prazosin, doxazosin, they are relatively safe and they do not alter the aldosterone renin ratio that much compared to the centrally acting drugs. So you can use peripheral alpha blockers and you can use this calcium channel blockers as well. So once you get the results of aldosterone renin ratio, you have to see whether it is less than 20 or more than 20. If it's less than 20, it effectively rules out primary hyperaldosteronism, and you have to think about other causes that causes hypertension and hypokalemia. If it's more than 20, usually it is suggestive of primary hyperaldosteronism, and further confirmation can be done by either a saline infusion test, or alternatively we have something called a salt loading test. Remember, this test is not needed. These confirmatory tests are not needed if your plasma aldosterone concentration is more than 20 and the patient is having hypokalemia. This is a clear-cut sign of primary hyperaldosteronism, and these tests are really not needed. In confusing states, you might be needing to do this test. For example, how will you do this test, saline infusion test? First, let us see how you are going to do a saline infusion test. So the principle is very simple. In saline infusion test as well as salt loading test, you are going to give sodium chloride, that is sodium load, to the patient. That should inhibit the renin angiotensin aldosterone axis by feedback. If it's not able to inhibit, obviously you are going to diagnose a excess. In the other words, the saline infusion test and salt loading test are like suppression tests. So this can be also called as salt suppression tests. So saline infusion test is usually done by infusing 2 liters of normal saline, that is 0.9% NaCl, over a period of 4 hours, typically from 8 a.m. to 12 p.m. And after 12 p.m., once you stop the infusion, you will be doing plasma aldosterone concentration. If it is less than 5, that is supposed to be normal. If it is more than 10, definitely it is suggestive of primary hyperaldosteronism. Similarly, you can do a salt loading test as well. This is not performed nowadays. Salt loading test, you have to give at least 5 grams of salt to the patient per day for at least 3 consecutive days. And it's very important that you have to monitor the amount of salt taken by the patient, because if the patient takes less amount of salt, then your results may not be appropriate. So you have to monitor the amount of salt patient takes by seeing the urinary sodium, which should be at least more than 200 milliequivalents per day, which tells you that the patient is taking at least 5 grams of salt per day. And after this, you will be doing urinary aldosterone concentration. If it is more than 12 micrograms per day in the 24-hour period, then definitely that is suggestive of primary hyperaldosteronism. If the salt suppression tests are negative, then you can rule out primary hyperaldosteronism. If the confirmatory tests are positive, then you can confirm. Obviously, these are confirmatory tests. Now it confirms primary hyperaldosteronism. Once you have confirmed primary hyperaldosteronism, next step is to see the age and family history, just to understand whether clinically you are able to differentiate familial hyperaldosteronism or not. If the patient's age is less than 20, plus or minus, if the patient is going to have family history also of either a early intracerebral hemorrhage in their family, or death due to hypertension very early in the life. So, or patients with severe hypertension early in the life in their family. So in this condition, in this kind of patients, you can directly go for genetic testing. That is the best, because it's very clear that these patients are likely to have familial hyperaldosteronism. The patient's age is more than 20 and they do not have any family history. So here you have to see whether surgery can be planned or not, whether the patient is willing for surgery or not. So if no, obviously you are going to treat with medical treatment with MRA plus or minus steroids depending on the cause. MRA is for multiple types of hyperaldosteronism. You can add steroids, especially if the patient is having salt retention due to congenital adrenal hyperplasia, or probably in patients with glucocorticoid remediable hyperaldosteronism. In those indications only we'll add glucocorticoids. Apart from that, mineralocorticoid receptor antagonists are more than enough. If surgery is not planned, then you can use medical treatment. If surgery is planned, then you have to localize. Localization studies should be done with the help of adrenal vein sampling. You can ask me, wait, so where is the imaging? Can I do a CT and MRA? No, CT and MRA has very poor role as far as hyperaldosteronism is concerned. because even though in CT or MRI, if you see an adrenal lesion, it could be a non-functioning adenoma. So you cannot be very sure that it's a functioning adenoma. So localization studies should be done with the help of adrenal vein sampling. If not localized, which means bilaterally there is excessive aldosterone. If it is not localized, then you go for medical therapy again. If it is localized and the patient is willing for surgery as well, then you can plan for laparoscopic unilateral adrenalectomy. Obviously, if it's a cancer, you will be going for open adrenalectomy, but if it's an adenoma which is going to be the common entity, so in those settings, you can go for a laparoscopic unilateral adrenalectomy, which is more than enough. Suppose a patient is having aldosterone drain ratio of less than 20, I told you that rules out primary aldosterone excess. So which means you have to think about other conditions that produce hypertension with hypokalemia. So it could be a secondary hyperaldosteronism, where vascular conditions and primary hyperrenism can produce a similar picture. So in this condition, you have to do a abdominal imaging versus renal artery imaging. So abdominal imaging in the form of CT or MRI to rule out a renin secreting tumor. And very commonly we'll do a renal artery imaging. That is more important because usually it will be a vascular cause, renal artery imaging. Low EABV causes need not be evaluated. I told you multiple times. Renal artery imaging can be done in the form of renal artery Doppler, which is preferred in the setting of high creatinine, or you can do a CT renal angiogram, or many extravagant studies are also there like captopril radionuclide scan assays, but we'll be discussing that in detail in the renal artery stenosis section. So CT renal angiogram is what you can prefer. This is very good if your creatinine is normal. If your creatinine is abnormal and elevated, then you can go for renal artery Doppler. Even though renal artery Doppler is not that good for diagnosing renal artery stenosis and renovascular hypertension. Or it could be due to apparent mineralocorticoid excess versus Liddle syndrome. So which means I'm talking about non-aldosterone mineralocorticoid excess. So now you have two conditions as I told you. One, you have to rule out apparent mineralocorticoid excess, especially due to your licorice ingestion or congenital 11-beta-HSD2 defect, or it could be due to Liddle syndrome. So whenever you think about apparent mineralocorticoid excess, first step is to rule out exogenous mineralocorticoid use. Whenever in doubt, you can even do a urinary steroid profile. Then once you have ruled out exogenous mineralocorticoid use, now the next step is to do a urinary cortisone to cortisol ratio, which will be usually less than 1 if it's a 11-beta-HSD2 defect. And this can be further confirmed by its responsiveness to spironolactone, that is mineralocorticoid receptor antagonist. Liddle syndrome, I told you it's an autosomal dominant, which means you definitely tend to have a family history here very clearly. At the same time, these patients can be diagnosed from the responsiveness to amiloride. They will respond excellently to amiloride, and that becomes a drug of choice for this disorder. So this is how you are going to approach and evaluate a patient with a suspected hyperaldosteronism, especially a primary hyperaldosteronism. In this, the usual question in exam is, the next step whenever you have a hypertension with hypokalemia, answer is aldosterone drain ratio, and they will be asking some details about this saline infusion test and salt loading test. So with this, we have completed hyperaldosteronism, and let us move on to hypoaldosteronism, its etiology and causes. You know, hypoaldosteronism is going to manifest with salt wasting, which can precipitate hypotension as well and shock, especially if there is a coexisting cortisol deficiency. The risk of crisis and hypotension and shock is very, very high. And the patients tend to have hyperkalemia, and patients also tend to have metabolic acidosis. And this metabolic acidosis, as I told you before, tends to be normal anion gap metabolic acidosis, NAGMA. What are the etiology and causes of hypoaldosteronism? Hypoaldosteronism can be due to low renin. As I told you, it can be due to low renin production. So what are the conditions that can produce low renin? This is called hyporeninemic hypoaldosteronism. So low renin may be due to certain drugs. So drugs like beta blockers, drugs like NSAIDs can produce low renin, and because of that they can produce hypoaldosteronism and its manifestations. How beta blockers can produce low renin? Because we know that juxtaglomerular cells can produce renin by three mechanisms. One is by detecting the perfusion and the volume. Second is by adrenergic pathway, that is through beta-1 receptors, and third one is through prostaglandin I2, that is prostacyclin, which is secreted by the macula densa. So when you block this beta-1 receptors by giving beta blockers, obviously you will result in low renin production and low aldosterone. If you block this PGI2 production by the macula densa by giving NSAIDs, automatically your stimulation of the JG cells will reduce, resulting in low renin production. That's it. So drugs are very, very important. And we have some conditions that increase the tubular fluid sodium, like for example a diabetic kidney disease, a glomerulonephritis, and can produce hyperkalemia and metabolic acidosis by producing low aldosterone and low renin. How is it going to cause low renin in these conditions? Remember, whenever you increase the tubular fluid sodium, the macula densa will be sensing more tubular fluid sodium, and they are going to reduce the prostaglandin production, which in turn is going to produce less stimulation of the JG cells, resulting in lesser production of renin in these conditions. And DKD, you know very well, diabetic kidney disease, which means diabetic nephropathy, is a hyperfiltrating kidney disorder, which means the entire spectrum of diabetic kidney is due to hyperfiltration only, and obviously they are going to produce excessive tubular fluid sodium, and that is the reason why you will result in hypoaldosteronism in this regards. And similarly, if you have a DCD damage, which means you're going to damage the macula densa by disorders like HIV or like disorders like chronic interstitial nephritis, you might result in lower prostaglandin production, and because of the same you might result in lower JG cell stimulation, lower renin production. And please understand the fact that these disorders are also associated with volume overload. Many of these disorders are also going to be associated with volume overload that might result in more production of natriuretic peptides. We all know this natriuretic peptides are direct antagonists of renin-angiotensin-aldosterone system, which means they are going to produce vasodilation, they are going to produce reduced angiotensin 2 production and reduced aldosterone production, and they also tend to produce natriuresis. So which means this could be a separate mechanism why low aldosterone is there in these patients. So but in general, in these disorders which I have mentioned, you have to think about hyporeninemic hypoaldosteronism as a pathophysiology, especially when you are studying about competitive exams. So then there are some other causes that can reduce the aldosterone synthesis from the zona glomerulosa, which means the problem is not in the renin production, which means here the renin production will be increased because of salt wasting caused by low aldosterone, but actually there is a problem at the production level as far as aldosterone is concerned. The aldosterone levels are low. This is called as hyperreninemic hypoaldosteronism. So the problem could be drugs like ACE inhibitors, which will reduce angiotensin 2, which will result in reduced stimulation of AT1 receptors, and which will result in reduced aldosterone production. Or it could be angiotensin receptor blockers, same effect. Or it could be some drugs like heparin, which also damages the angiotensin 2 receptors, producing similar effect. Or there could be some problem in the zona glomerulosa itself, like adrenal insufficiency. A lot of cause of adrenal insufficiency we have discussed in the previous chapter itself, so I'm not going to discuss anymore. So the causes include drugs like ACE inhibitors and angiotensin receptor blockers. And heparin, as I told you, heparin damages the angiotensin receptors, AT1 receptors. Because of that, they can result in hyperkalemia and aldosterone deficiency. And second is adrenal insufficiency. There are a whole lot of causes of adrenal insufficiency. All of these things can produce aldosterone deficiency and hyperkalemia. Similarly, if there is some problem at the action of aldosterone, if the action of aldosterone is defective, there is some issue over here, defect in the aldosterone action. So this is what we refer to as aldosterone resistance or tubular resistance to aldosterone. In this condition, your aldosterone levels also will be high, your renin levels also will be high. It's a straightforward thing because it's a resistant state. It's not aldosterone deficiency, it is resistant. This is also a type of hyperreninemic hypoaldosteronism only, but actually here it is aldosterone resistance rather than a deficiency. Resistance can be at the level of ENaC channels, resistance can be at the level of mineralocorticoid receptors, or resistance can be at the level of sodium potassium ATPase, which is also very important on the basolateral side, which is going to respond to aldosterone. So ENaC resistance can be due to a condition called pseudo-hypoaldosteronism, which is an autosomal recessive disorder, which I'll be discussing in some time, or it could be due to usage of drugs like amiloride or triamtrin. Remember, there are some drugs which mimic these ENaC blockers like pentamidine and trimethoprim, and those drugs can also produce aldosterone resistance and hyperkalemia. Mineralocorticoid receptor level resistance is commonly encountered in another disorder called pseudo-hypoaldosteronism type 2, which is autosomal dominant inheritance, which we'll be discussing subsequently, and it can be due to use of mineralocorticoid receptor antagonistic drugs like spironolactone or eplerenone. Sodium potassium ATPase level defect can be due to usage of drugs like calcineurin inhibitors. Calcineurin inhibitors means I'm talking about cyclosporin and tacrolimus, and these drugs can damage the basolateral sodium potassium ATPase. Because of that, your aldosterone may not act properly and the potassium cannot be pushed into the cell. Then only your potassium can be moved out of the lumen, moved out of the cell into the lumen. So because of that reason, you might result in hyperkalemia and aldosterone resistance like picture. So these are some of the reasons, very important reasons, where you can develop hyperkalemia due to aldosterone resistance rather than aldosterone deficiency. But there are a lot of other causes which can do the same, like amyloidosis, which also generate aldosterone resistance because of some tubular problem, and conditions like sickle cell disease can produce tubular resistance to aldosterone by the same principle of damaging the tubules, and they have poor response to aldosterone. And you can have another disorder called transient pseudo-hypoaldosteronism, which usually happens in the setting of urinary tract infection, especially pyelonephritis and obstructive uropathies, where there will be a tubular resistance to aldosterone. Clear? And it's prudent to understand the causes of pseudo-hypoaldosteronism in a little bit of depth, because this could be exam questions. You have two types of pseudo-hypoaldosteronism. One is type 1 and type 2, even though the transient type can be discussed along with it. Let me discuss later on, and we are going to see the clinical features. Type 1, you know, it's autosomal recessive in its inheritance, and it is due to defect in the ENaC channel, epithelial sodium channel alpha subunit. Remember, it's the loss of function mutation. Liddle syndrome, gain of function mutation, gamma subunit. PHA type 1, loss of function mutation, alpha subunit. Whereas this type 2 pseudo-hypoaldosteronism is autosomal dominant inheritance, and the problem is at the mineralocorticoid receptor. And type 2 generally tends to be mild and reversible almost completely by adolescent life or adulthood, whereas type 1 tends to be severe and mostly irreversible, full spectrum of manifestations including hyperkalemia, metabolic acidosis, and salt wasting causing hypovolemic hyponatremia. And at the same time, they tend to have systemic features also that is very striking in this disorder. Systemic features include lung involvement resulting in recurrent infections, which can predispose to the development of bronchiectasis, and these patients may have colonic issues resulting in diarrhea, because mineralocorticoids are very important for three organs: colon, sweat glands, and kidneys, and they can result in increased sweat chloride levels as well, which also means that a very, very important DD for this PHA type 1 is cystic fibrosis, which can have almost similar findings. But please understand the fact that PHA type 1 tend to have metabolic acidosis, whereas cystic fibrosis patients tend to have metabolic alkalosis, and cystic fibrosis patients does not have hyperkalemia, whereas this type 1 PHA patients will definitely have hyperkalemia, and this type 1 PHA patients will not have steatorrhea, and cystic fibrosis patients will have steatorrhea due to pancreatic insufficiency in many of these children. And finally, you have a transient pseudo-hypoaldosteronism, transient PHA. usually happens in the setting of pyelonephritis, that is upper urinary tract infection, and in the setting of obstructive uropathy, where there will be severe resistance to aldosterone by the tubules. But this is completely reversible once you relieve the obstruction case of obstructive uropathy and treat the pyelonephritis with appropriate good antibiotics. And there was another type of pseudo-hypoaldosteronism called as Gordon syndrome, and previously called as pseudo-hypoaldosteronism type 2, no longer called by this name, and many nephrologists even think that this is not even a type of pseudo-hypoaldosteronism. It is due to mutations in the WNT1 and 4 gene, which is present in chromosome number 12 and 17 respectively, and it's an autosomal dominant disorder. So it used to result in a pathologic mechanism called as gain of function mutation of thiazide sensitive transporters in the kidney that is present in the DCT. We know this thiazide sensitive sodium chloride transporters in the kidney are seen in the DCT. If there is gain of function mutation in these transporters, that is the cause of Gordon syndrome. So how can you understand this? So this is the DCT, and you have a thiazide sensitive sodium chloride transporters, and because of the WNT1 and 4 mutations, it will result in gain of function of this sodium chloride thiazide sensitive transporters, where there will be increased sodium reabsorption and increased chloride reabsorption, both of which are going to result in obviously hypertension, at the same time hyperchloremia, and at the same time they will suppress the renin angiotensin aldosterone axis. And these patients also tend to have hyperkalemia. One of the main reason is low aldosterone, no doubt about that. Apart from that, multiple reasons are there. One reason is this WNT1 and 4 mutation will also result in relative loss of function of ROMK potassium channels, which cannot expel potassium outside, and that is the reason why you might result in hyperkalemia. Similarly, because of low sodium delivery, we know that sodium delivery is very, very crucial for potassium secretion. Because of the low sodium delivery, and more sodium is getting absorbed at the DCT level itself, and reduced sodium delivery at the collecting duct level, there might be hyperkalemia. And because the low sodium delivery, these patients may have increased potassium retention, H plus retention as well. That is reduced H plus secretion, resulting in normal anion gap hyperchloremic metabolic acidosis, NAGMA. So clinical features of Gordon syndrome: hypertension, hyperkalemia, normal anion gap metabolic acidosis, and hyperchloremic metabolic acidosis, and many of these patients may have arthrogryposis as well. Finally, let us summarize. Hypoaldosteronism can be divided into hyporeninemic hypoaldosteronism and hyperreninemic hypoaldosteronism. Hyperreninemic can be further divided into aldosterone deficiency and aldosterone resistance, and the differences between the two can be done in the form of fludrocortisone test, where aldosterone deficiency will respond to fludrocortisone test and aldosterone resistance will not respond to fludrocortisone injections or fludrocortisone tablets. The details of this fludrocortisone test will be further discussed in the hyperkalemia chapter, because all the causes which I have told you under hypoaldosteronism are very, very important causes of hyperkalemia under hyperkalemia chapter as well. So let us discuss in detail there. So now this must be more than enough. And let us summarize by writing plasma aldosterone concentration on one side and plasma renin activity on other side. So if you have low plasma aldosterone concentration, low plasma renin activity, you clearly know that it is hyperreninemic hypoaldosteronism. And if a low aldosterone with high renin, it is aldosterone deficiency. If aldosterone is high and renin is also high, it indicates aldosterone resistance. Hyporenism, obviously you will be treating with high dose fludrocortisone. Usually the dose needed here is a little high, 5 to 20 times more than what you use in adrenal insufficiency, like 0.2 to 1 milligrams per day is the dose needed. Aldosterone deficiency, most of the times it means it's adrenal insufficiency, where you need hydrocortisone alone most of the times, especially if you're using at a dose more than 50 milligrams per meter square per day. You don't need additional fluorocortisone, which I've discussed multiple times in the past. But if you're using, if you're using this hydrocortisone at a lesser dose, then you might be needing to supplement with fluorocortisone, which is usually given at a dose of 0.5 to 0.05 to 0.1 milligram OD or BD. That is, the total dose is 0.05 to 0.2 milligrams per day. Aldosterone resistance, on the other hand, most of these conditions will be having some underlying problem. If you correct that itself, it's more than enough. But in conditions like pseudo-hypoaldosteronism, especially type 1, which is very difficult to treat, you might be needing to treat them with salt replacement because they may not have good response to fluorocortisone. And at the same time, you have to give fluorocortisone plus or minus carbenoxolone also. Carbenoxolone works by inhibiting 11-beta-HSD2 enzyme, which means this drug increases the cortisol's action on mineralocorticoid receptors, especially in the kidney. So that might help, especially in highly resistant scenarios like pseudo-hypoaldosteronism type 1. I think we have discussed in detail about hyper as well as hypoaldosteronism, and some of these things and the basics will be carried over into the potassium homeostasis and hypo and hyperkalemia as well. So in the next section and the upcoming sections, we'll be discussing on the potassium disorders.